from here. This is also a site where we have some drug excretion going on in this area here. And we're going to be secreting a lot of our nitrogen wastes. Nitrogen waste. Can you tell me a little bit about these nitrogen wastes? Can you tell me about where creatine comes from?
Muscles.
Creatine comes from muscle. Urea comes from
Guanine and thiamine.
right. Urea primarily comes from the breakdown of amino acids. It's a less toxic form. Ammonium would be the more toxic form that has not get converted into urea. So we also can get rid of some nasty ammonia as well in here. Nitrogen wastes we're getting rid of in that proximal tube. All right. The nephron loop. I just want to show you this picture here before I go back to the text and point out that the nephron loop, which is going to be dipping down into the cortex, into the medulla that gets very hypertonic, all right, has a couple of very different regions, all right? As filtrate sort of passes through it, it's first going to go down this portion here. It's going to be called the descending limb. And then what filtrate is left is going to go up the ascending limb. So we have two very different limbs of the nephron loop, an ascending and a descending limb, that have very different properties. The descending limb, and I'll go over this multiple times here, the descending limb is permeable to water. Aquaform, descending limb, permeable to water, impermeable to solutes. I sure can. That the descending limb is permeable to water. Impermeable to solids.
Is ascending is going to be opposite way around? With the ascending with the ascending ones is going to be like the opposite way around?
A little bit. The ascending limb is impermeable to water. And it's not that the ascending limb is permeable to solids. The key thing about the ascending limb is we're actively transporting salt out, sodium chloride pumps. It is just loaded with sodium chloride pumps to pump salt out of the forming filtrate. So ascending limb, tell me what's going on, ascending limb? No water can get through it, but what are we pumping out of it? Sodium chloride.
Impermeable to water and without sodium chloride.
But we're pumping out sodium and chloride. Again, remind me about the descending limb. Permeable to water. Impermeable to any kind of solids. The ascending limb. Impermeable to water, but loaded with pumps for sodium chloride, because we're going to be pumping massive amounts of sodium and chloride out. So as we take a look at the characteristics of this loop here, now we'll just go through slide to slide, and then we'll talk about Canadian geese, of course. Why wouldn't we talk about Canadian geese? So our thin segment, the big part that's going down, we know is what? Permeable to water, but impermeable to solids here. most of it's this thin segment, that's the only one we're worried about here. Whereas the ascending limb is full of pumps for what? Sodium and chloride. You can sort of see all the sodium chloride pumps pumping out sodium and chloride from which limb here? From the ascending limb. So what is this all about? And how on earth did Canadian geese get into this picture? You're probably wondering about that. Maybe you're not wondering about that at all. Maybe you just want to get through this without having to wonder anymore. That's okay.
I'm thinking about it.
Showing a goal here, close enough. This is showing a goal. Canadian geese the same way. Hasn't this kept you up at night wondering about how these Canadian geese in terms like this can stand on ice all day, all night long and not freeze to death? Hasn't been like keeping you up at night? It's like, why? Why can they do that?
Yeah,
I just don't get it. And the answer is a mechanism that's referred to as countercurrent exchange. Let me explain that to you real quickly, how this countercurrent exchange works. Is that going down into the feet, all right, we have an artery that's running exactly next to a vein. They are touching each other. That's how close they are. Artery going down, vein going down into the feet, all right? By the time the blood reaches the feet, it's basically almost at freezing temperature. Basically, it's close to freezing temperature, about 1 degree. As the venous blood starts to rise up, going back into the body, this freezing cold blood, it's passing next to an artery whose blood is slightly warmer. And so as it goes up, all right, it's going to the venous blood is going to start to pick up heat from the artery that's right next to it. So the temperature of the venous blood starts to go up. As it goes up a little bit even higher, the blood in the artery is even warmer, picking up more heat, until by the time it gets back to the body, it's basically picked up all that heat, and it's basically body temperature. What about the arterial blood? Well, as the arterial blood's going down into the feet, as the arterial blood goes down to the feet, it's losing heat to the vein next to it, correct? And so by the time that arterial blood gets down into the feet, it's losing all of its heat to the vein heading back up. So by the time that arterial blood has gone down to the feet, it's basically at a freezing temperature. So because of this mechanism, they lose virtually no heat, because what we're picking up on one side is being lost on the other side. Understand a little bit now? Can you sleep better now? Now I know why Canadian geese and terns can sleep. They call it a countercurrent. The countercurrent exchange, the only thing that makes it work is that the two fluids in this case here have to be going in opposite directions. Arterial blood heading down, the venous blood going up. If they weren't going in opposite directions, you wouldn't get this, but you'll understand why this is important in a minute. Because we see something almost identical in the kidney. Let me see if I can make this a little bit bigger. Now, I have to throw some numbers at you. Have to do that. We've already said that the fluid up in the outer cortex is basically isotonic, right? So that's why you're seeing this number about 300 millismolar up here, all right? But as you sink deeper and deeper into the medulla, I want you to notice what's happening to the osmolarity and the interstitial fluid surrounding it. It's starting to do what? Go up. Is it going up just a little? It is going way up, all right? They're showing it going up to about 1,200 millismolar by the time it reaches the bottom. And there's some evidence that it actually goes up closer to 1,400, maybe even 1,600 in some nephrons, the juxtamedullary ones whose loop goes way, way, way down, all right? Even more so. So why am I bringing this countercurrent up here with this increasingly sort of salty, increasingly hypertonic area? Well, we're going to start by taking a look at the fluid that's heading up here, because as we go up the ascending limb, it's impermeable to water, right? But it is permeable to, not permeable to salts, but it's loaded with pumps for salt, right? Sodium, potassium, right? Now, we will see in a minute, by the time the fluid gets down the very bottom of the nephron loop, it's extremely concentrated. Because the descending limb that's going down here, we've said is permeable to water, right? And because it's permeable to water and it's passing through this extremely hypertonic area here, water is being drawn out of the descending limb by what process? Osmosis. So by the time that we get down to the bottom, we've lost maybe another 10 or 15% of the volume. Remember, we lost 70% already in the proximal tube. We're going to lose another maybe 15% or so by the time we get down to the bottom. Another 15% of the fluid drawn out. So by the time we're at the bottom, the filtrate itself is going to be just as hypertonic as the surrounding area, which means it's going to be extremely hypertonic down here. As we start to go up the ascending limb that's loaded with sodium chloride pumps, right? Think about this just for a second. Is there going to be a difference in the amount of substrate the pumps near the bottom have to work with versus the ones at the top? A big difference, because down at the bottom it's extremely hypertonic, all right? These pumps here have easy access to salts, right? It's just concentrated. So the pumps down at the bottom are going to be what? Extremely busy, extremely active, pumping out massive quantities of what? Salt. Keeping the area down here what? Extremely hypertonic, right? As the filtrate starts to go up, what's going to happen to the concentration of the filtrate? It's going to start to become more dilute, right? Because we're pumping out all the solids, right? Which means as I go up, there's going to be less and less for the pumps to grab onto, meaning the pumps are going to do what? Pump out less salt as we go up, right? Because if we're pumping less salt as we go up, the amount of concentration in the surrounding area becomes what? Less and less. By the time we get to the top of it here, they're not showing it, but it's a number that I'm going to expect you to write down. By the time we get to the top and we're into the distal tubule, the concentrate of the filtrate is down to about 100. Down about 100, 150. By the time we enter the distal tubule, the concentrate of the filtrate is down to roughly what?
100.
About 100 to 150.
Is that the number that you're going to put on the exam?
Mm-hmm.
To 150? Like a range like that?
Or I might put one of those numbers down.
Oh, just one of them.
Yeah.
Okay. Not like, oh, A is 100, B is 150.
Right.
I'm so good.
I am evil, but there is a limit to that. But the other detractors would be things like 50, 300, 1400. The other numbers would be well outside of that range here. The key thing about it is that we are very hypotonic by the time we get to the top. Now, all of this stuff that's being lost, fluid that's being pulled out, for example, all right, has to be then picked up by these peritubular capillaries that are surrounding it, right? That's how we get all the material back into circulation, right? if the blood were flowing in the same direction as the filtrate were flowing, all right? As we would go down here and we start to pull things out, then the blood itself would start to become more dilute as we go down, right? And it would wash out any kind of concentration gradient that would happen. But fortunately, the only reason this works is that the filtrate and the blood flow are going in opposite directions. That's what makes this system work, that the filtrate and the blood are moving in what directions? Opposite directions. So as we start to pull out pure water from the forming filtrate here, right, the blood supply that's going past it, all right, is going to pick it up and then head out of the kidney, all right? Heading out, because as we go up, as it picks up fluid, it's going to get more dilute and more dilute going up anyways, right? So it works only if the fluid and the blood are going in what directions? Opposite directions. So this is what they're trying to sort of show again on these diagrams here, showing the difference. They're trying to show you how concentrated the areas in the deeper medulla are here. Showing that the descending limb permeable to water, so we lose a huge amount of volume as we go down. Huge amount of volume go down. As we go up, we're pumping out salts. So the truth is there's very little, because salts by themselves don't contribute much to the volume. As we go up, there's very little change in volume, because really volume changes are linked to water gain or lost. So because as we're going up, there's very little change in volume, but there is a massive change in its concentration, right? As we go up the ascending limb, what's happening in the concentration of the filtrate? Is it becoming more concentrated or more dilute?
More dilute.
It's becoming more dilute. From like a 1200 near the bottom up to maybe 100 or so by the time we get to the top. Okay, now we're into the distal tube. We've lost 70% by the time we left that proximal tube. We've lost maybe another 15 or so percent or more by the time we've gone through that. So we're down to maybe about 15% of the volume that's left. That's about all that we have left here. And we now have more of our nitrogen wastes that are actively pumped into it and are not removed, very little removed, that are going to make up a greater portion of the solutes now. When we first started, most of the solids were like electrolytes, sodium, potassium, maybe some nutrients like glucose. By the time we're in the distal tubule, we've pulled out so much of the things that we want to save, the electrolytes, the nutrients, that most of the solids that are left behind are the ones that we want to get rid of. The urea, the other types of nitrogen waste here. Now, the distal tube and the collecting ducts are the last two parts of it. And they are under hormonal control. They call it facultative absorption.
You said they are under what?
They call it facultative. Let me see if I can find. Let's see if Key issue here, right, that's happening is what they call facultative water reabsorption. This is what's happening in the distal tube and in the collecting ducts under hormonal control. And the hormone that's going to have the biggest impact in this area here is ADH, our old friend ADH. The other hormone that's going to have an impact is aldosterone. So let's talk about how these two hormones work, what their roles are. This should be a review that we've talked about multiple times. That aldosterone is a hormone that's primarily a blood pressure hormone that was released in response to the renin-angiotensin system, everybody's favorite, or not. And aldosterone basically activates sodium-potassium pumps, pulling out sodium and an osmotic equivalents of water. So of course, anytime I am retaining sodium, I would be eliminating what ion? Potassium. And again, this is primarily there to control blood pressure, because when I retain salt and water, your blood pressure goes up. All right. Without aldosterone, if I eliminate salt and water, then my blood pressure should be going down. So one key thing about aldosterone is that it's going to have an impact on the volume of the filtrate that's left here, but not much on its concentration, because we're pulling out both salts and water. So aldosterone has a minimal impact on the concentration of the forming urine, just how much of it you're producing. Do I need to repeat that?
Yes, please.
Aldosterone has minimal impact on the concentration of the filtrate and urine.
But it has a big impact on the volume.
Yes.
Has minimal impact on urine and what was the other?
Filtrate,
Right.
concentration, and filtrating.
Filtration.
So for example, low blood pressure would trigger the release of renin from that juxtaglomerular apparatus that we spoke about in our last exciting class. And the renin, of course, would convert angiotensinogen into angiotensin 1 first. It gets converted by ACE, angiotensin converting enzyme, into angiotensin 2, which is the big thing that will trigger the release of aldosterone. Increasing aldosterone. And in response to increasing aldosterone, bless you, you're going to be activating pumps for salts, and that will pull out water as well on the distal tube and a little bit of collecting ducts. And because of that, you'll produce a relatively low volume of roughly isotonic. Roughly isotonic. what are you trying to read here?
As a word under isotonic,
That's urine.
Okay, sorry.
Are you disrespecting my handwriting here?
No, I just
Are
sometimes.
you coming for me here?
No, I would never.
You know, I was sick for like a week in second grade, okay? When I worked on handwriting, I just really never caught up. So, isotonic. And again, so on the other hand, let's say you drink like, let's say you're gonna drink like 6 glasses of something that's more or less isotonic, like a slightly dilute Gatorade. Are you with me? The reason I'm having you drink this right now as a experiment here is because if I drink things that are isotonic, is that going to have an impact on the osmolarity of my bodily fluids if what I'm drinking is isotonic? If what I'm drinking is basically 300 milliosmolar and my bodily fluids are 300 milliosmolar, let me ask you again, will drinking that have a big impact on my concentration? No, it's not going to have an impact on the concentration, right? So it's not going to have an impact on ADH, because ADH release is dependent on changes in that concentration. So how can I get rid of all this extra salty fluid here? Well, this extra salty fluid would cause my blood pressure, at least partly, to do what? Go up, all right? That would stop the release of what hormone? Aldosterone. And instead of conserving salt and water, I would do what? Eliminate salt and water. So I would produce a high volume of more or less isotonic urine. So in response to drinking all of this isotonic fluid like Gatorade, all right, the lack of aldosterone will cause me to urinate out those 4 or 5 glasses of isotonic fluid. It would be different if you were to drink pure water. Why? Because drinking pure water is going to have an impact on your osmolarity. Would being dehydrated also have an impact on your osmolarity?
Yes.
And that's going to be triggering a different hormone, of course, which is ADH. Oh, since I have the bullet point up here, let's mention this real quickly. We've talked about this before, the importance of calcium, and that calcium reabsorption is going to be done in the distal convoluted tube under the control of the 2 hormones that regulate blood calcium levels, which are calcitonin and parathyroid hormone, PTH. Do you remember those 2 hormones at all? PTH was released if your blood calcium levels drop, like you haven't had enough calcium. And it's going to help you try to retain calcium. Now the problem with PTH is, aside from making your kidneys try to pull as much calcium back out of the urine as you can, if you don't have enough urine there, you already learned in 109 that PTH will cause your bones to become demineralized, potentially leading to osteoporosis.
Alright, so quick decision.
Hmm?
The concentration is only dealt with in the nephron loop, but ADH and aldosterone control so much as we absorb.
Right, and you hold on to that thought for 1 second. We've talked about how ADH will cause you to pull pure water out of the forming urine because it has an impact on concentration. How does it do that? It works primarily on the distal tubule. Let me explain how that would work here. So here's my distal tubule. And the distal tubule is traveling through this very hypertonic medullary areas, correct? Where it's basically like a 1600 by the time it gets to the bottom, extremely hypertonic by the time we get to the bottom. Without, and I said that the filtrate when it's reaching the top here, without all hormones involved, is very hypotonic, right down to about 100 millismolar, very dilute. Without ADH, And you would not be secreting ADH if you are overhydrated. If you're overhydrated, no ADH release. Overhydrated, which means that your bodily fluids are basically hypotonic. All right, you're too dilute. This area stays impermeable to water, which means that this very dilute filtrate is just going to pass right through. And you produce a very high volume of very dilute urine. But if you're dehydrated, if you are dehydrated and your osmolarity is now going up because you're dehydrated, ADH activates those aquaporins that allow water to pass through. So this area, under the control of ADH, becomes permeable to water. And so in that way, it's going to act a lot like the descending loop. So as the filtrate passes through this collecting duct here, all right, in the presence of ADH, with all these pumps here, we're going to be pulling out what from it? Pure water. There's no solids can get through. We're just pulling out what? Pure water. ADH allows for the removal of what? Pure water. And in that case here, you would be producing a very small volume of a very concentrated urine. So if you are dehydrated, you'll secrete a very, and as you pull that pure water out of the forming urine, you will produce a very low volume of very concentrated urine. On the other hand, if instead of drinking 6 glasses of like Gatorade, I were to drink 6 glasses of pure water, is that going to have a different hormonal effect? Yeah, the 6 glasses of pure water are going to cause me to become overhydrated, really. My osmolarity would go down. And again, if I'm overhydrated, low osmolarity, overhydrated, would trigger your ADH release to do what? Go down. And that would cause you, again, the filtrate is just going to stay in its intact form all the way down. So we're going to produce a very high volume of very dilute. Alcohol inhibits the release of ADH. I think we had that conversation. So because of that, drinking alcohol has the effect of dehydrating you because it's going to cause you to produce a high volume of very dilute urine. Would you also have this sort of issue if you sort of had some hormonal issue that prevented you from secreting ADH? There is another condition that's called diabetes insipidus. Diabetes insipidus is not the same as diabetes mellitus. Diabetes mellitus, that's sugar diabetes. That's an insulin issue. Diabetes insipidus is a problem of not being able to secrete enough ADH. Now, this condition, diabetes insipidus, is not nearly as bad as diabetes mellitus. Doesn't have any of the other kind of complications. In fact, a lot of people that have low-grade levels of diabetes insipidus never even have that diagnosed. They just find themselves peeing more than other people, drinking more than other people. You're still gonna have that high urine output, probably a little thirst going along with that for dehydration, but you're not gonna get the damage to microcirculation like you get with diabetes mellitus or the other issues you get with diabetes mellitus. So if you had to choose between having diabetes mellitus or diabetes insipidus, that's an easy choice for you to make. You're gonna take diabetes insipidus every time. It's not nearly as common a condition as diabetes mellitus, and again, it's not nearly as aggressive to your body. Everybody okay with these distinctions here? And how the two hormones work? Are they involved in obligatory water reabsorption or facultative water reabsorption? Facultative, because under hormonal, your body adjusts. When they talk about facultative, it's adjusting it based on your needs. That's the whole idea between the facultative. It's adjusting it based on your what? Needs. Your needs. And again, the main two hormones, ADH and aldosterone. There are other hormones like atrial natriuretic factor. I'm not going to test you on. It doesn't seem to have a lot of clinical relevance as far as I can tell right now, which is why we're not going to go in that. All right, we've talked about the countercurrent exchange mechanism and how that works. This slide sort of gives you a nice little overview of the main things that are happening in each of the little different parts of the nephron loop. Just an overview again, most of the water gets reabsorbed via this obligatory water reabsorption that's happening in the proximal tube in the nephron loop here, all right? The facultative water reabsorption allows you to fine tune it again based on blood pressure issues, based on osmolarity hydration issues here, this facultative water reabsorption. Again, ADH is the one that's primarily going to be changing that here. ADH increases, more water gets reabsorbed, urine volume decreases, osmolarity increases. And the last couple of slides on this one here are just sort of showing you what would happen under conditions of normal hydration, that would be euhydration, versus being dehydrated or overhydrated. And I think you already kind of know the answers to those things here. If you're dehydrated, what hormone is going to be kicking in here? ADH is going to be increased. And in response to the ADH, you're going to try to conserve water. You're going to decrease your urine volume. That's going to increase its concentration up to like 1,400. And that's about the maximum concentration that you can produce in your urine, about 1,400. Because again, that's how salty, how hypertonic the medulla gets. Now, some helpful tips, not on the test, but just some helpful tips if you should ever find yourself lost at sea. Right? How many of us have had that happen to, right? You're on a cruise ship like that, all right? The weather starts getting rough. Your tiny ship gets, oh wait, no, that's Gilligan's Island, I'm sorry. But okay, so you're out in the ocean, right? And you start to get thirsty. Can you be drinking seawater? Why not?
Too much salt.
Because it's too salty, all right? It's basically about double this concentration here, which means that for every like 1 ounce of water that you would drink, your kidneys would have to pee out like, basically like double that much. It would just dehydrate you even more. But you can get fluid if you can catch fish. Because ocean fish have mechanisms to get rid of extra salt from their body. They pump it out of their gills. So if you can catch fish, all right, and sort of get your fluid from the flesh of the fish, you know, they don't have a lot of blood in it, but you get your fluid that way, that is actually hypotonic, all right? So that you can survive on an ocean as long as you're just consuming what? Fish. Now I talk about fish, I'm talking about regular fish, not sharks, because sharks have the same tonicity as ocean water. They don't have to worry about issues here. They have lots of urea actually in their bloodstream to make them isotonic to salt water. It's the other type of regular fish, like a tuna or a sea bass. Those are the ones you want to be catching. Leave the sharks alone, leave the shark fin soup alone. Just eat fish. So, were you going to ask something or no? Just stretching? Okay. Because sometimes I'm not sure when people are, oh, is this a question or is this just a stretch, people? All right. All right. Let's finish. Your analysis. Have we talked about, have we talked about what you should or should not find in the urine? Just a short list, just a really short list of abnormal things. Just a short list of abnormal things. Right, that kind of thing. I know I probably mentioned it, but I'll just do it again. No blood cells. You should not find red blood cells or white blood cells. If there are red blood cells, it's probably a problem up in the glomerulus where the filtration, that's basically the only place that blood cells could get into it. In the glomerulus, in that tuft of capillary, which often means that there's some sort of infection that's affected the glomerulus, or some kind of, like a glomerular nephritis would be an example. I'm not going to test you on this, it's not a class in pathology, but that would be where that is, and where the damage would be. And I want you to understand that'd be different because if there are white blood cells in that, that's almost going to always be an issue with a UTI, urinary tract infection. The white blood cells are coming from the distal end of your urinary tract, not the proximal end. Just as a quick note about urinary tract infections, I'm sure since this is a class that is laden with estrogen, that most of you are probably familiar with, that women are much more likely to suffer from urinary tract infections. They can get in the bladder again because of a short urethra.
Lucky you guys.
Yeah, if it weren't for the fact that our gonads have to be out there and hanging in the wind, right? Because that's kind of a downside. Now, this might kind of sound, this will undoubtedly sound disgusting, but I'm going to mention it anyways here because I've heard these stories before. If you're working in that kind of clinical situation, or you're going to patients repeatedly here, and you have somebody who's repeatedly getting urinary tract infections, right? One thing, I know this is disgusting, one thing you want to make sure that they understand is that they need to be wiping in the correct direction. Because some never learn that, all right? Or especially because guys wipe in a different direction, all right? Guys generally just take the easy way out. They don't have to worry about it. They just wipe from back to front. That's a guy's wiping issue here. More than you ever needed to know probably about that, all right? Which is often why men end up with streaks on their underwear here. Don't want to get too graphic. Women, of course, should know better than to do if they were trained where they're going to wipe backwards here so that you avoid going near the vagina or urethra here. But there's some women apparently who have been raised by wolves who have never been taught that. and who then, because of that, don't understand the differences and get repeated urinary tract infections. And it can be just something as simple as teaching them what direction to go. All right. So you should not, again, no red blood cells, no white blood cells. There should not be protein.
Oh, yeah.
That also generally means that there's a problem in the glomerulus with the filtration that's going on in the glomerulus. And then, so the last thing I will mention would be nutrients like glucose. Should be at maximally, a trace amount maximally.
This glucose in your urine, that means you're diabetic?
That usually means that you're diabetic, or you've just raided a candy store or something like this, and have eaten your entire bag of Halloween candy in one sitting. That'll put you into, all right, into that condition as well here. But usually, right, you're talking about diabetes here. Now, this is not our maybe time to do this, but I think we've talked about before the A1C test. Have we talked about that test in here? Which is
What is it for?
the A1C is a standard test for diabetes these days, for diabetes mellitus. Now, I can't test on this because this was chapters ago we would have done this here, but it's worth knowing a little bit about this because you're going to get this test on a regular basis here. Hemoglobin eventually picks up sugar molecules. The more sugars in your bloodstream, the more your hemoglobin gets exposed to it, and some of the hemoglobin molecules will have sugar molecules attached to them. And the test for that is what they call the A1C test. And the beauty of the A1C test is that it gives you, because how long do red blood cells last? About 100 days or so, right? About 3 to 4 months. The A1C test gives you a long-term idea about how much what your blood sugar levels have been. So I shaved my mustache off after we did this picture here, but. The A1C, so it tells you what percent of your hemoglobin has actually been saturated with sugar here. Normal levels, you want it generally around 6 or so. They're sort of showing, I'm not going to test you on these sort of levels here, but what they're sort of showing here is that there does tend to be a correspondence to your average blood sugar levels, all right, by doing it this way. Now, if you're a pregnant woman, for example, they cannot use an A1C test to test for gestational diabetes because you're not worried about a 100-day average. You need to know what your blood sugar levels are like right now. And that's why they make you drink that horrible, basically it's like corn syrup, I think, with little flavor into it. Basically make you drink this corn syrup and then see how much you pee just a short while later. They still have to sort of do that sort of test here. But this gives you, the A1C gives you a long duration, about a 3-month average about what your blood sugar levels have been. And this has been the best way to sort of monitor people's blood sugar levels. Before that, if you just get a blood sugar level done when you get your blood workup done, that can be affected by a lot of things. Acute changes, what you ate for breakfast or lunch or dinner, whether it's fasting or non-fasting, where none of that is an issue with A1C levels. That's why that's sort of, these days the A1C is sort of the gold standard for that. But you should not find glucose in the forming urine. Usually it's a sign that, again, diabetes might be. All right. I'm not gonna, would you expect, let me just do the following, see how much we can remember. Would you expect to find urea in the urine?
Yes.
Creatine,
Yes.
uric acid,
Yes.
all of the different types of nitrogen waste you would all normally expect to find in there. All right, so we've made urine, how do we get it out of your body? Now, did we talk? Did we go over the collecting system before in here about how the urine, once it's formed, enters into the minor calyxes, and then the major calyxes, and the renal pelvis, and then the ureter? We did do that already, right?
Yeah.
So once it's in the ureter, it's going to be taken to the bladder by peristalsis. Peristalsis will take it to the bladder for temporary storage. The bladder has a muscle in it that's called the detrusor muscle, smooth muscle, that's under parasympathetic control. So just showing the bladder. I think we've already mentioned that the bladder and the ureters are lined with a transitional epithelium. Does this sound familiar?
Mm-hmm.
Transitional epithelium. The transitional epithelium was one that allowed for very rapid stretch and rebound. That's very helpful because you need your bladder to be able to expand, to drink, to hold a lot of fluid, and be able to rebound very rapidly here. And just as we have with the digestive system, the exits will be controlled by two sets of sphincters. An internal sphincter, which is smooth muscle, and an external sphincter that is skeletal muscle. Now, we've mentioned already that the length of the urethra leading out is different from men and women. Women, much shorter, again, that can lead to urinary tract infections. For men, it's important to know that the urethra has two distinct regions to it. That the initial big part of it has to go through the prostate gland, runs right through the middle of it here. And they refer to that as basically the prostatic urethra. The other part of it goes to the penis. They call that region the spongy urethra. And the issue for men, because the prostatic urethra has to go through the prostate, it's very common for men to start to generate an enlarged prostate gland. They get into their 50s and beyond like this, it starts to grow and enlarge. And as it grows and enlarges, it's going to compress the urethra, making the passage of urine very, very difficult, having difficulty. There are different type of treatments they can do. In severe cases, they can basically go in there like a roto-rooter and basically just root out a direct passageway right through the prostate gland here. But this is a common issue here. Are women going to have this issue?
No.
Not normally.
No. It's small.
So finally, micturition reflex. That's the $20 word for urinating, the micturition reflex. That's going to be primarily mediated out of the lower portion of the spinal cord. The sacral region of the spinal cord is where all of these impulses go. When your bladder fills with a given volume, all right, there are stretch receptors in the bladder here, stretch receptors that are going to activate this. They send signals right to the, again, sacral region of your spinal cord, because this is a parasympathetic mediated effect. Just like defecation was parasympathetic, urination, micturition is also parasympathetic mediated. So parasympathetic ones are going to stimulate the detrusor muscle here to contract. That's going to trigger the internal sphincter to relax. And that's going to create a head of pressure that's going to drive urine out of your body. Now, normally, there's a link between the two sphincters, so that when the internal one sort of relaxes, the normal external one, keep in mind, skeletal muscle, you have to consciously keep it contracted, correct? All right? So normally when the internal one sort of relaxes, all right, you're just going to avoid your bladder. Now, you're at a really nice window in your lives where you've got control over that external skeletal muscle sphincter, so you can prevent yourself from urinating where it might not be convenient or socially appropriate. But again, that's keeping clamped down on which sphincter? On the external one, because the external one is the one that is skeletal muscle. Now there are links between them, so if you voluntarily try to relax the external one, you can relax the internal one. So if you're going on a long car ride, and it's like, okay, try to go to the bathroom before you go. You all know what that's like, where you can sort of force yourself maybe to go when your bladder maybe isn't quite ready at that point there. And again, just showing the reflex going on here. There's also control level, not just at the level of the sacrum, but the brainstem, specifically the pons. Yes, our old friend the pons. That we normally just associate with having areas that are going to be involved with modifying respiration, but they also have areas that are involved in the micturition reflex. All right, so we've already said cerebral cortex can promote the relaxation of the external ones, and you can go even when the time is being up. And that is the end of our semester.
Oh my God.
No.
I promised myself I wouldn't cry. It's all right. So, to remind everybody what's going on now, all right? Because even though this is our last lecture here, it ain't over till it's over, people. So, Tuesday, lab final and nothing else, correct?
Yes.
So again, there will be no lecture beforehand. We're just going to meet in lab, and we're going to do this. We're reversing the order of the two groups. So if you were in the late group, which I think was L to Z last time, then you're going to start right away at when we would begin, which is what, at
240?
240.
Yeah. Right? Yeah.
Right.
240,
Wait,
yeah.
L to Z, like the last name? or the-
Last name.
Well, just
I
remember,
was
The beginning will be.
if you're in the late
So
group, then
just
you start at
remember-
240.
Yeah.
So if your last name, so if your last name is A through, I think it was A through L maybe.
No, I think this class have a bigger group for like A through C or A through D in this
Yeah,
class.
because I was in the late group, my last name.
That's okay. So if you're in the second group, this time you're in the first group.
Yeah.
Yeah, it works better that way. So everybody knows what group they're in when they're going to be coming.
I'm in the late.
So that is,
Yeah.
you know, if you're not sure, just show up for the early group, and if I've got enough room for you, I'll get you in on the early group.
So what's the late, what's the time for the late one?
Hmm?
What's the time for the late?
3:40.
Would be 3:40.
You have an hour.
3:40, you said, you have an hour?
Yeah.
It would be. Let me make sure I've got our times.
For the lab final, you said we gotta know the pig parts, and we gotta know the pre-lab activities we just did, and you said we gotta know about the lipids or something.
Yeah,
Yeah, that-
the chemical
my
experiment that we did.
Right.
You should send out the.
Right, so anybody who came in, let me just real quick here. still to finish up here, then still next week, next Thursday, we have our exam. And there's gonna be, again, that's gonna be our third exam that's just gonna be on these 2 chapters. All right? Not a whole lot of material on this one here. We're gonna be covering metabolism and the urinary systems. And that's gonna be probably won't even be a full of 70 questions on this. Probably close it at 60. Because we're only not 20. Keep working that. And then the following week, May 5th, will be 2 Thursdays from now, is when we're gonna have our cumulative final.
Oh my God.
Oh, my goodness. I thought that was the.
Mm-hmm.
May 5th, Thursday, May 5th.
At what time?
We're gonna start it at 1 o'clock.
That means.
I'll put this up on Canvas also. I'll put an announcement that'll have the time. And it'll be in this room from 1 to 3 o'clock.
So we don't have to come Tuesday, because there's no.
No. Right, so on finals week, you don't come in at all on Tuesday. Just coming in on Thursday for the test. 100 questions. Multiple choice, bring your lucky number 2 pencils with you. The overwhelming majority of the questions are gonna come directly from the old test, the lecture tests. So start to go over lecture test 1, lecture test 2. And that will be it. Okay. Anybody who came in late once?